So our first speaker is Dr. Neil MacIntyre. Dr. MacIntyre is Clinical Chief of Pulmonary Critical Care Division, Professor of Medicine and Medical Director of Respiratory Care Services at Duke University. Please help me welcome Dr. Neil MacIntyre.
Thank you. Well, that was quite an introduction. It is fun being here in Tennessee. A bunch of old friends showed up, and well, actually, they live here. I guess it's not called showing up, but it was really fun last night. Colleen and Candy were my dinner partners along with my wife. I had 3 lovely women next to me. It was pretty cool. Anyway, it's fun to be here. I've never been to this part of Tennessee. I've been to Nashville, the big cities. The mountains really are very pretty. My wife said, we need to go to Dollywood. And I said, whoa. Anyway, it's closed today, so such is life. All right, let's see. I've got there is a timer there. There we go. And there I am. So what I was asked to speak on for the next 45 minutes or so is non-invasive ventilation for chronic respiratory failure. And by chronic respiratory failure, we're talking about pulmonary disease. I'm not going to speak to the issue of the neuromuscular patient, spinal cord injuries, and the like. We're going to focus on mostly chronic respiratory failure, which really in practice means mostly COPD. But some of these points will apply to other forms of chronic respiratory disease. So, these are the objectives. We're going to talk about what chronic hypercapnic respiratory failure is, talk a little bit about physiology and how NIV might address that, and then the challenges, and there are a lot of challenges. Relevant disclosures, obviously Encore Health, I'm grateful to for sponsoring, and there's some other people who are sort of involved in these fields that I get asked to consult for. So, this is what I want to cover, like I said, in the next 45 minutes or so. What is chronic hypercapnic respiratory failure? Why do people get it? What's the impact of it? And then move on to NIV, non-invasive ventilation, and its design features and physiology and why it might address these problems. There's a growing evidence base supporting the use of these devices. And then the far more difficult challenge in speaking, talking about the incredibly complicated regulatory issues. So first, chronic hypercapnic respiratory failure, the mechanisms, the clinical impact. And I think of respiratory failure, hypercapnic respiratory failure, as being an imbalance here between between capabilities on the right, demands on the left. Capabilities are the respiratory drive and the respiratory muscles. Demands, how much ventilation do you need? And mechanics. And first, the demands. In chronic respiratory failure, especially COPD, the ventilation demands are high. First off, they're working harder to breathe, but just as importantly, if not more so, dead space creates a huge problem and increases the ventilation load. And of course, the mechanics are awful. Very high resistance systems. And this is a little cartoon that I think every respiratory therapist in the world knows. Airway obstruction. Airway obstruction is caused by narrow airways that are inflamed, often have a lot of mucus in them. This increases inspiratory work. The muscles are loaded. In fact, they're overloaded. And the narrow airways increase air trapping, hyperinflation, and this leads to dead space. So you can see there are a lot of issues going on in the chronic obstructed patient. A little physiology plot, looking at the work of breathing on the vertical axis versus ventilation on the horizontal axis. And you and I are down there at the very, very bottom, those little lines that say N. And the patients we're dealing with are the ones that have O. And if you've got some restriction as well, you're an RO and you really are in trouble. And you can see the work of breathing, which you and I in the room, about 5 joules a minute, that's what you and I are breathing right now, can go up to exceeding 20 joules per minute. And fatigue is thought to set in somewhere around 15 to 20 joules of work. So it's not hard to picture these people having demands that overload the respiratory system. And of course, complicating that is you've got you've got capabilities that also suck, if you will, particularly the muscles. The muscles are badly damaged in chronic respiratory failure through a variety of mechanisms. First off, they get tired. They're overloaded. But these patients are malnourished. They're hypoxemic. And then you get this interesting phenomenon that we've only appreciated for the last maybe 10 years or so. COPD is not just a lung disease. COPD is a systemic disease. There's inflammatory stuff being generated in the lungs, cytokines of all shapes and sizes. These get into the bloodstream, and they cause multi-organ failure, the cachexia, the multi-organ dysfunction syndrome. You guys all know about ARDS if you work in ICUs. ARDS is not just a lung disease, is it? It's a systemic disease, and COPD is exactly the same way, and this affects the respiratory muscles. And then, let's make this even more complicated. This hyperinflation pushes the diaphragm down, and a flat diaphragm can't contract. And the diaphragm accounts for about 80% of your inspiratory capability. And if that's flattened and unable to contract, you've lost an awful lot of force-generating capability. So you can see this is really a combination of a bunch of bad physiologic phenomenon. And this is showing you what happens to, these are normal patients that were given increasingly loaded breathing. And as you can see, eventually, even in normal people, the end-tidal CO2 will start to rise as a consequence of all these derangements. The lungs just can't cut it. And complicating that is the brain is not a dummy, if you will. The brain recognizes that the muscles are in big, big trouble. And so the respiratory drive, as you get sick, first of all, it gets stimulated as you start to get sick. But when you really are overloaded, the system actually puts a brake on your ventilation. So the hypercapnia is not only from overload, but the respiratory drive itself in the severe stages starts to down-regulate, if you will. The implications of chronic hypercapnia, this was a reanalysis we did a couple of years ago with some fellows back at Duke. And these are not surprising findings, but the results come from a huge body of COPD patients being considered for lung volume reduction surgery. And it's not surprising. The predictors of hypercapnia, a high ventilation demand with respect to your MVV, a low FEV1, hypoxemia. And then there are associations that also are not surprising. Presence of sleep apnea, low quality of life scores, and low maximum inspiratory and expiratory pressures. The implications again, in severe COPD, gold stage D, you can get up to a third of patients have chronic hypercapnia. So it is not uncommon in the very severe COPD patients. And the consequences, these have been shown in many, many, many studies. Patients with hypercapnia are more likely to get exacerbations, have more right ventricular dysfunction, and then what is really important, they actually have a worse mortality. And this is a nice plot that was published a few years ago, back in 2014, showing that as your CO2 retention worsened, your mortality rose in a rather dramatic fashion. So this is a bad situation. This is a bad situation. So, enter stage left, non-invasive ventilation to the rescue. I'll talk a little bit about design features and the physiologic effects of NIV and why this may be important in these chronically hypercapnic individuals. So you all know what these are like. You're experienced respiratory therapists, all kinds of different gadgets out there and all kinds of different interfaces out there. I won't belabor all these. You know these probably better than I do. NIV basically has two fundamental design concepts. One is you take a traditional, conventional ventilator with a dual limb and an exhalation valve and outfit it with a mask. These masks invariably have leaks, and so you have to modify your conventional ventilator to deal with these leaks. That's a rather complicated way of delivering NIV, but it can be effective. Dedicated NIV ventilators are a little simpler. They use a single limb, and it's usually a turbine or some form of compressor that generates two levels of pressure, and a leak is built into the system. So it's a flow-through system, if you will, with higher pressures during inspiration, lower pressures during expiration. And this is an easier system to build. Leak management is easier with these kinds of systems, and these are the systems that normally would end up in somebody's home. We tend to use pressure-targeted modes rather than volume-targeted modes. These are a little easier to deal with in these single-limb circuits. Dealing with leaks is a little bit easier. And I'll put my prejudice in here. Pressure-targeted modes tend to be more comfortable. The two common modes are pressure-assisted control. That means it cycles on a timer you set, or pressure support, which cycles on a flow measurement. So the physiologic effects of non-invasive ventilation. First off, it augments ventilation and unloads muscles. And this little cartoon I've got here illustrates this. This is a volume over pressure curve. This is you and I sitting here in the room, negative pressure, generated tidal volume. Everything's cool. The little dots there represent the work of breathing. This is somebody with bad respiratory mechanics, and the pressure requirements are much higher. The work of breathing goes up. Everybody understands this. This is controlled mechanical ventilation. The patient doesn't do diddly squat. Ventilator does everything for you. This is the patient just triggering the ventilator, just a little bit of work down there. This is what you're trying to do with NIV. Well, actually with any form of interactive vent support, but especially with NIV. Deliver an appropriate pressure and flow so that you unload the muscles and literally try to create the loading that you see over here, trying to mimic normal. So you want to mimic a normal tidal volume and a comfortable patient. This is what you don't want. This is called flow dyssynchrony. The flow and the pressure is not keeping up with patient demands, and you get a patient who is uncomfortable. And this is where the skill of a respiratory therapist can be critical, setting up that flow and pressure profile in a manner that creates this rather than this. So the augmented ventilation and the less muscle loading actually can reset the capnostat. I like that term. It's that part of the ventilatory control system that drives ventilation based upon CO2 levels. And by unloading the muscles, you're telling the brain, hey, it's not so bad down there after all. You can restore some of that ventilatory drive. And the brain may actually reset itself and actually drive the CO2 down a bit. It may not go to normal, but it may get a little bit better if you can properly unload the muscles. You can use expiratory pressure to recruit alveoli. This is usually not a problem in patients with chronic chronic hypercapnia. They're not atelectatics. But expiratory pressure has a very unique role in COPD patients in making it easier to trigger the ventilator. What goes on? I think the best way to illustrate this is with my hands. You and I in the room, this is alveolar pressure, this is circuit pressure. You drop your alveolar pressure, your circuit pressure drops immediately. Ventilator recognizes that, bingo, it fires. With these folks with hyperinflation and air trapping, their alveolar pressure is way up here. So they have to suck it all the way down before you finally change the pressure in the circuit and trigger the ventilator. This can be a tremendous load on patients. So we're not using PEEP in the traditional way, that is to recruit alveoli. We're using PEEP instead to try to make it easier for the patients to trigger the breath. How do you set that? How do you adjust that? You'd like to do it with a thing like that can monitor effort, like an esophageal balloon. I realize most of you do not routinely use esophageal balloons. I don't routinely use it. But you got a nice tool right here, a nice sensor. It's called your hand. And you put your hand on the chest and you feel the patient's effort. And in this situation, there's a tremendous effort, and you can feel the effort, and the ventilator acts as if nothing's happening. A long delay, or it may miss the effort completely. First time I saw this a number of years ago, I said, my goodness, what a crummy ventilator. It wasn't the ventilator's fault at all. And you can actually assume what I call the intrinsic PEEP position. Nothing up my sleeves. Left hand on the chest, right hand on the PEEP knob, or button now, eyeball on the vent. And you start titrating, 2, 3, 4, 5 centimeters of PEEP. And if you're doing the right thing, the effort you sense over here ends up with a much more responsive delivery of gas by the vent. You rarely need more than about 7 or 8 centimeters of water. It's really kind of cool to demonstrate this in the ICU, which is where I normally work, but it applies to non-invasive ventilation as well. Don't always worry about just setting up the inspiratory pressure. The expiratory pressure can play an important role in patients having triggering difficulties. What's kind of interesting is that if you just use these devices at night and unload muscles at night and make them more comfortable at night, you may lower the CO2, but you certainly can help the respiratory muscles, and it actually makes them function better during the day. And we'll talk about that in some of the clinical studies I'll show you in just a moment. So you don't necessarily have to wear it all the time, which is kind of nice. So let's talk about the clinical studies supporting all these concepts I've been delivering here. Using positive pressure ventilation is not a new idea. Not a new idea. Studies go back, I remember when I was a resident back in the late 70s, early 80s, people were trying to bring in ventilators with masks attached to them for these chronic patients to try to blow them down, so to speak. Negative pressure devices were tried. Small studies were done. I say negative studies here. There were conflicting studies. Some people claimed that it seemed to help. I remember one very positive study that looked really cool. The PCO2 was blown down by nocturnal ventilation, and everybody was patting themselves on the back. Study was over, and none of the patients wanted to take it home. They said it was just too big, too cumbersome, too noisy, too this, too that. So even though the numbers got better, the ultimate outcomes were not very impressive. Later in the 1980s into the 1990s, these so-called bi-level systems, those non-invasive ventilation systems with the single limbs came into play. The term RADS was coined. I'll come back to RADS in a minute, a respiratory assist device. The FDA does not recognize the term RAD. It's either a ventilator or it's not a ventilator. CMS and payers have coined the term RADS, and we'll come back to that point in a moment. But these were devices that you could give maybe 10 to 20 centimeters of inspiratory pressure, maybe a little bit of PEEP, that seemed more comfortable. Patients were more tolerant of them. But I summarize here in 2013, 9 years ago, the Cochrane Review, those words are kind of small down there. The concluding line is, the small sample sizes of these studies preclude a definitive conclusion regarding the effects of non-invasive ventilation and COPD. So 9 years ago, people still weren't sure if this was really worth the trouble. And then came this evolution of the high pressure approach. This started in Europe. Don't use just 10 to 20 centimeters of water. Push the pressure into the 20s. Get a full face mask, more than 6 hours a night. They often had to hospitalize them for a week or more to get them used to these very high pressures. And go after the CO2. Really try to drive the CO2 down. I hope my German friends out there won't be offended, but this was in Germany, and people often chuckle. They say, in Germany, you can do that. You can tell the patient to sit down, shut up, and wear this high pressure. Take that for what it's worth. This is from a graphical tracing showing you spontaneous breathing, low-level non-invasive ventilation, high-level non-invasive ventilation. And you can see the airway pressures here getting up in the 30 centimeter of water range over here on the right. And the patient really kind of stops breathing with this very aggressive approach. These are some tables showing you what happens. It's very interesting. As you go to high-pressure non-invasive ventilation, the breathing frequency really doesn't change much, but the inspiratory time gets shorter and shorter and shorter. And that's because the tidal volumes are getting bigger and bigger and bigger, and the brain is not dumb. The brain doesn't want air trapping, so it shortens the inspiratory time, lengthens the expiratory time to minimize the effects of air trapping. But it does affect the respiratory pattern. Well, you all might say, well, so what? Does this actually improve anything? And this is one of the earliest approaches with a fairly modestly high level of nocturnal NIV. And sure enough, the PCO2 does come down. It doesn't come down a lot, but it comes down about 5%. This translates into a very borderline benefit in terms of 6-minute walk distance. So it's not a negative study, but it certainly doesn't knock your socks off. Better outcomes were measured here. This is looking at things like quality of life and the like. The patients who received non-invasive ventilation did get better. They felt better. They had less dyspnea. And this persisted over the course of a year. What was really important, however, though, is that in these patients, despite these rather modest outcomes, looked like they had a pretty impressive reduction in mortality. So NIV, at least being more aggressive with it, sort of took foothold back, 8 years ago now? And the concerns, there were of course concerns, intrinsic PEEP and air trapping. I mentioned to you already that the brain did a good job at minimizing air trapping by shortening the inspiratory time when it did. There's theoretical concern that these high pressures may generate tidal volumes that may produce ventilator-induced lung injury. This high minute ventilation and intrinsic PEEP might compromise cardiac filling. And then there's always the concern, what if you unload the muscles too much? Disuse atrophy. So there are a lot of concerns about it, but subsequent studies also using more aggressive forms of pressure have kind of confirmed these results, that you can get better function during the day. You can drive the PCO2 down, even though it's not very much. Patients, at least in Germany, will put up with this aggressive form of non-invasive ventilation. Is this my recommendation for use in the United States? No, I don't think so, and I'm going to explain to you why I don't think you have to be quite that aggressive. Because I want to go beyond this sort of high-level non-invasive ventilatory support. There are smaller devices out there, portable systems, and a key component, well, I'll get to my key component in just a second, that allow these devices to not only be used at night, but also, if you want, actually during the day with activities of daily living. Lower pressures, using it not only at night, but also during the day for exercise, pulmonary rehabilitation, things like that. And what this concept is showing us is that you really probably do not have to drive the CO2 down. These very aggressive approaches that try to push the PCO2 down can push the PCO2 down, but respiratory muscles, if you unload them, may keep the PCO2 where it is, but they function better. And I think that's a very important concept. I think in our studies, we need to get away from this notion that the device is no good unless it can drop the PCO2. And CMS and others are kind of hung up on that concept, but I think it's an important one that we emphasize. And I showed you that earlier study that showed things like quality of life, numbers of exacerbations, mortality. All of those can probably occur with trivial, if any, changes in PCO2. So you don't have to drive the PCO2 down. And this takes us to the realm of devices that don't use necessarily very high pressures, but can be portable and be used to improve function, not only at night, but during the day. And this is a really nice study by Rich Casaberry's group. I really like this. These are 10 hypoxemic, hypercapnic patients treated with 4 different levels of support. On the left is just air. And what we're measuring is the endurance, the capability, and the right panel is dyspnea. So we start with air, and then we add a little portable ventilator, no oxygen. These are hypoxemic patients. That didn't seem to help too much, and I think the message is clear there. Ventilation is not going to fix hypoxemia. The third panel is just oxygen, and oxygen does help hypoxemia. You all know that. But what's kind of cool is if you put the two together, the far right panel, you get an added bonus. And the dyspnea scores follow pretty much the same way. Pretty much follow the same pattern. I got interested in this system This was a study using a little portable ventilator that was manufactured at the time by Breathe. And you guys in the industry drive me nuts, because Breathe got bought by Hillrom, and then Hillrom got bought by Baxter, and I'm not even sure who owns them right now. You guys, it's like a moving little shell game out there. Anyway, it's a clever little ventilator that you can wear. It's got a nasal interface. And this was looking at 16 patients who were willing to put this on during their activities of daily living for a year. And it was an observational study, but it was kind of interesting, because if you looked at ER visits with before and after, they did seem to go down. Inpatient admissions went down. Inpatient days and ICU days, well, ICU days went to almost zero. So the CAT scores, the Medical Research Council scores, all seemed to get better. So where are we with clinical studies? There's a growing literature out there. Nocturnal NIV in hypercapnic COPD patients can lower the CO2, Doesn't have to, but it can increase functional status. And as I showed you, there's even at least one good study that suggests there may be a mortality benefit. So nocturnal NIV in COPD patients, hypercapnic, if the patients will tolerate it and put up with it, and you set it up properly, can have good outcomes. And I've proposed to you that maybe we can extend this beyond nocturnal NIV. We can actually put it into activities of daily living with devices that can be carried around on your belt and maybe powered by rather simple compressors or even just a simple oxygen source. And now, with 26 minutes into my 40-minute presentation, I have to take a deep breath, because this is where it gets complicated. Regulatory issues. Here we've got a technology that seems to benefit, that not only seems to benefit the most severe, but may actually extend into patients who are ambulatory. And how do we get this? How do patients get access? So home non-invasive ventilation includes RADs and ventilators. This is what the DME companies are dealing with. You have to understand a DME company, and I sympathize with them. They are just that, a durable medical equipment. They are not a clinical support entity. And that's a big, big problem. And I'll come back and touch on that problem in a moment. In other words, they only supply devices. They supply none of the clinical support that goes with those devices. At best, you may get a technician who can fix it if it breaks. So that's a huge, huge problem right now. The DME is responsible for these complex pieces of equipment with no access to clinical support whatsoever. And CMS is not dumb. We can think they're dumb, but they're not. CMS is not dumb. They recognize that there is minimal clinical support. And they decided that if the device is being used for sort of non-life support applications, it's not really a ventilator, and they call it a RAD, a respiratory assist device. In contrast, if they think that this is being used as, quote, a life support technology, they'll call it a ventilator. And the reason that distinction is important is because if you get a ventilator, you at least get the technical support to fix it and adjust it. And many DME companies, to their credit, their support technicians, technologists, often have respiratory training. So it's sort of a backdoor way of getting some clinical support in to help you with your device. But again, there's no clear technical difference. There's no clear technical difference. The FDA does not recognize a RAD. And ICU ventilators technically could function as a RAD. Bring your Puritan Bennett 980 into your bedroom, and you can set it up in a non-invasive mode, and technically your CMS would look at that as a RAD, because it's only being used, say, for more complex sleep apnea. On the other hand, you can take rather simple non-invasive design systems and make them into ICU ventilators. And you guys who went through COVID, which I think is probably all of you, probably remember, I know we did it in our institution. We had patients in the ICU on V60s, so-called non-invasive ventilators, and we were treating them just like ARDS. So the distinction is really a weird one. CMS distinguishes it on its application rather than its technical specifications. And that creates real problems in trying to write regulations. So a RAD is a non-support application. A ventilator is a life support application. So here's some sort of technical mumbo-jumbo on these things. The ventilation assist device, I don't know why they label it that. People always call them respiratory assist devices, versus life support, and just some examples that show you life-sustaining support device. I would submit to you that the Trilogy and the Life 2000 both could be used in an ICU, and actually were used in an ICU to support patients during COVID. Sorry, I should have been on the other side. Some of those other non-invasive RADs were also used in the ICU to support COVIDs. Anyway, you can see that technically there are differences, but for the most part, there's no clear line in the sand that separates a RAD from a ventilator other than its designed application. The big problem is because it's a RAD, it gets reimbursed at a much lower rate. These are old data. Don't write them down. The DME people who might be here in the audience are saying, well, that's not what I'm getting today. I know that. I get that. I just put these numbers up as illustration to show you that if you get qualified as a ventilator or a patient who needs a ventilator, you get a heck of a lot more money. You get a heck of a lot more money. So, how do you get these things? It turns out not only are RADs paid less, they're more complicated to get. Well, that's weird. Because to get a RAD, you have to go through, at least at the present time, overnight oximetry that demonstrates you have some hypoxemia. Hypercapnia, rule out OSA. To get a ventilator, you don't have to do the overnight oximetry. You only have to say that you have severe COPD that implies it's life-threatening COPD, and you have to have that same PCO2 threshold of above 52 millimeters of mercury. So ironically, it's easier to get a bilevel RAD than it is to get a ventilator. Guess what? Clinicians and suppliers are not dummies, and the ventilator business has skyrocketed. The ventilator business has absolutely skyrocketed. And this just shows you, again, same kind of data showing you that the patients getting home ventilators have gone through the charts. And this is, I find, very, very interesting. In 2009, on the left, you can see the number one reason to get a ventilator in the home was a neuromuscular problem. Chronic respiratory failure only accounted for 29% of home mechanical ventilators. But by 2015, with these documentation implementations, look at that. Chronic respiratory failure, usually COPD, 85% now. 85%. So this is a weird system. It's a weird system. Clinicians want to supply non-invasive ventilation to COPD patients with hypercapnia. Evidence supports the benefit of that. Everybody, even the DME people will agree with that. But to get paid for it in a reasonable amount and to get at least a technician who may hopefully have some respiratory background, you've got to qualify the patient for a ventilator. And ironically, CMS makes it easier to qualify for a ventilator. So people do it. So people do it. The American College of Chest Physicians, the American Thoracic Society, the American Academy of Sleep Medicine, and the AARC put together a technical expert panel almost a year ago now to try to come up with some semblance of order here to make it more straightforward to get the right device for a patient, and proposed this schema. So it starts with severe COPD. All you have to do is show hypercapnia, rule out OSA. You don't need a sleep study. You don't have to go see Dr. Landon. You don't need a sleep study. Start with a non-invasive system, a BiPAP system. Notice we didn't use the word RAD. We said a bi-level non-invasive ventilation. On the left, if the patient's adherent for more than 4 hours per day and they are evaluated and things are going well, ventilation goals achieved, you stay on that system. You stay on that system. To go down the panel on the right, you need to have higher pressures than the usual bi-level system can supply. Again, if you're in the believer of 25, 30 centimeters of water inspiratory pressure, I'm not a believer. I think you can accomplish this without such excessive pressures. If you need a high level of FiO2, you got a very hypoxemic patient. If you have a need for mouthpiece ventilation, that's pretty unusual. And it is a life support device, so you need a backup and a good alarm system. So if you do that, you can initiate a ventilator. And if you fail the little panel there in the middle, if ventilation goals are not achieved with the BiPAP or the bi-level system, you can flip over to the home mechanical ventilator. So this was proposed. We proposed this, I was on this panel, with some trepidation. Because in a way, we're sort of pushing people to go down the bi-level route, which clinically makes some sense, but economically does not. So, like I said, we put this proposal forward with some trepidation, a lot of asterisks and appendices and everything else saying, but in doing so, you can't cut the reimbursement rates for these people who really do need who do need non-invasive ventilation. So where did this recommendation go? As you can see, it was just published a few months ago. Yeah, that should be 2022, not 2021, sorry. We were seeking a national coverage determination. This is a policy that's followed by Medicare across the country. If you don't have a national coverage decision, how is it decided? Your local Medicare intermediary makes the call. So people in Western Tennessee may have a different set of rules than people in Eastern Tennessee, and different from my home back in North Carolina. And it causes problems, especially if you're taking care of patients who live outside your particular region. So that's what we were after, is a national decision. This takes a long time, a lot of discussions, a lot of this, that, and the other thing. And I won't go through these in great detail, but as you can see, it takes a long time. People get asked, advisory panels are set up, et cetera, et cetera, et cetera. It is a complex problem. And unfortunately, the initial response from CMS is, oh my God, you guys are totally upsetting the apple cart. We're too busy. We can't handle this right now. And they tabled it. It was labeled as too complex. Not necessarily over. There are appeals boards, reconsideration, etc. As I said, I'm still a little going down this path with some degree of clinical enthusiasm, but very nervous economically. Very nervous economically. And I think what we need to do in parallel is two things. Two things. Number one, link complex devices with appropriate clinical support. Devices cannot be managed from a website. Cannot be managed from a website. And what I think is important to point out, and we've pointed this out to Medicare, and that the standard of care, SOC, standard of care, in all the clinical trials, that were dealing with this subject, used on-site clinical support. So all the trials that showed benefit to nocturnal NIV had clinical support, every one of them. And Medicare, in its goes back to what I said at the very beginning, or much earlier in my presentation. I'm sorry, we are DME companies. This is out of our hands. Go talk to somebody else. And that's exactly what has to be done. In dealing with the federal government, or at least CMS in this particular area, we cannot do this with one agency or one funding source. We have to get two. And we have to get the two to talk to each other. Holy smokes. Holy smokes, trying to get two government agencies to work together? Yikes. Yikes. So these are really daunting challenges. These are really daunting challenges. And my heart goes out to my colleagues here in the room who run DME companies. You guys are really between the proverbial rock and a hard place. You've got a very useful clinical tool. You've got a reimbursement system that totally disincentivizes the cost-effective way of getting this done. And I'm hoping maybe we can make some headway through this technical expert panel and trying to push on Medicare. Our lobbyists at ATS, ACCP, AARC are working hard. The lobbyists will tell you at this point, when you're really mired down in government stuff, you have to often go to a legislative fix. What's that mean? That means you bypass CMS altogether. Screw you, CMS. And you get a bill. Now, you never get an isolated bill on non-invasive ventilation in the home. That's not going to happen. The way the U.S. Congress works is it's a addendum to some spending bill for, I don't know, military equipment or whatever, that puts it in there and forces CMS's hand to straighten this mess out, and it is a mess. The second thing is I think it would help us a lot if we could at least speak a correct language and get rid of this RAD concept. Yes, it's useful to talk about indications and applications for a non-invasive ventilation, but it is a non-invasive ventilator. And the DME folks need to stop pussyfooting around and recognize these are all ventilators and deal with it accordingly. As I said, the design features overlap considerably. The current reimbursement in reality is based on clinical goals, but is forced by Medicare rules to stick to just devices. This is artificial, this is confusing. And I want to put in another comment here that I think the Europeans have got the right idea here. If you really want to simplify this system, do what the Europeans do. And what do the Europeans do? They have no RAD ventilator dichotomy. It's a home ventilator, usually non-invasive. We're talking about mask ventilation. And reimburse on how much you use it. If you only use it at night, that's a person who is not life-threatened. That is a person who is functioning reasonably well, and by unloading their muscles at night, you improve their function during the day. If you use it more than at night, and you actually end up using it during the day, be it ambulation or be it sitting in a chair or whatever, the reimbursement, presumably the patient is sicker and needs more attention, and the reimbursement rate goes up. So there's no ventilator distinction, it's hours of use. Well, that's a huge radical change. It probably is not going to happen, but you guys are my friends, and I can at least tell you what I think might help clear up this mess. So, I am now at the 42-minute mark. That means I got 2.5 minutes. I've got 8 minutes. Oh, my goodness. Well, let me tell you some stories. No. Let me kind of summarize my take-home messages here. Chronic hypercapnic respiratory failure in COPD, if you're in severe gold stage D COPD, that means you're a frequent exacerbator or have a bad FEV1. As many as a third of those patients will have chronic hypercapnia. It's multifactorial in its etiology: overloaded narrow airways, hyperinflation, overloaded muscles, malfunctioning muscles, all lead to hypercapnia, and the brain contributes to this by ratcheting down the drive in very severe conditions. The clinical impact is huge: functional loss, quality of life loss, hospitalizations, mortality. NIV is a really clever way of approaching this. How much pressure should you use during inspiration? There is a debate. Can you get away with modest levels that are comfortable, or do you need to be really aggressive? I'm not sure I know the answer to that. really aggressive does drive CO2 down more commonly, but I'm not sure that translates necessarily into better functional outcomes. The clinical studies, earlier studies were not all that impressive, but larger studies with larger numbers of patients have demonstrated not so much an improvement in CO2. Yeah, can be a little bit, especially with high pressure strategies. But again, I don't think you necessarily have to push the pressures into the high 20s or even low 30s. I think you can do this with pressures in the teens. And the idea of using it during the day, during ambulation, with lightweight, portable type systems, to me is really appealing, although I must admit the data supporting that is lacking. And the regulatory issues, I think I've berated that one about as hard as I can. So I planned this to go 45 minutes, so we'd have about 5 minutes, maybe if people have questions or comments. My God, it's 44 minutes and 43 seconds. Yikes, I'm good. Okay, thank you all very much for your attention. So Colleen has pointed out that we do have about 5 minutes, if there are interesting questions or comments out there. Thoughts? Yes?
My name is Bob Smoky. I'm from Florida.
Uh-huh.
And I'm a patient and a respiratory therapist
Oh, nice combo.
with a company called Breathe Strong America, Community Education. And my question comes from something happened to me a month ago. We're setting up for a pulmonary meeting in Southwest Florida a week before Ian hit us. Okay? And I get a phone call from my friend John, a patient in Arizona, who we have a relationship with through our Symposiums.
Okay.
And John says, Bob, I'm having difficulty on navigating my situation with BiPAP or ventilation support. It turns out he exactly fit your profile of some hypercapnia, hypoxemia, that fails his overnight oximetry, doesn't quite fit all the T's for all the RADS documentation. And I said, why don't you try high flow nasal cannula?
Oh boy, okay.
So it turns out that I got a hold of my DME friend in Arizona to help him navigate to his pulmonologist. And I get a call from John a week later. Bob, I've got this little ventilator, 4 pounds, in my home. I've expected something huge. And it's one of the major manufacturers that are out here in the room. I won't get into the branded thing, but I was amazed myself. This device is a ventilator.
But you're talking about a high-flow nasal cannula system.
Yeah, it's Louisa.
I'm not familiar with
It's
that.
a Movair device. It's being sponsored here.
Somebody has to help me. Does it
Yeah, it's new to
supply?
me too.
It's a high flow ventilator. It's a ventilator and a high flow device.
It can do both.
Oh,
You'll have to see it. It's next
I
door.
have to see
I
that.
gotta share that with you because it's really happening now, and I'm amazed.
Yeah.
And I just want to encourage
Yeah, well,
coaching and working together with our DME.
There's very little evidence. Absence of evidence is not proof of absence. So be careful here. The high flow devices are very clever. And again, you guys are experienced respiratory therapists. You know how these systems work as well as I do, maybe better. But it's a high flow. It's a high continuous flow. We'll come back to your device in a second. But the conventional devices are a continuous flow of very high flows, up to 60. I think some of you can go up into the 80 liter a minute range. You can put a lot of oxygen in them. They're humidified. They clearly wash out dead space and lower your ventilation demands. And they provide probably a small CPAP effect, which can help with ventilation. So they're very clever devices. Looking at them, they've been most studied in hospitals, usually with hypoxemic respiratory failure. People like the idea that they're kind of a comfortable CPAP system. Granted, the CPAP probably isn't very high, but maybe 5 centimeters of water. And extrapolating that to the home has been proposed. Trying to get that much oxygen flowing in the home is challenging. The people who make oxygen concentrators are pretty clever. People who use transfill systems are pretty clever. So there's a lot going on. The reason I didn't discuss it is because there's almost no data on whether these things really provide the benefits. But you bring up interesting stuff. Now, you guys are telling me that you can get a 60 liter a minute high flow device that does what? It adds inspiratory pressure at the same time? Or it's a ventilator or a high flow? Ah, gotcha. One box, two modalities. Gotcha. Yeah, well, a lot of, in the ICU, we're seeing the same thing. Conventional ICU ventilators are putting high flow capabilities on there. So, yeah, you and your friend may be onto something.
Well, I called a week later, or a couple weeks later, how you doing? And I want to clarify with this pulmonologist who gave it to him with the comment, you're getting the Cadillac of our ventilators.
Yeah. So, it's a fascinating idea. I just have zero data as to whether it's actually going to make a difference, but it's a fascinating idea. Now it's 50 minutes. Now I have to shut up. Okay, I'll be back in about an hour or so and with some other discussions. Thank you all again.